Well, welcome to this week's episode of The Dental Guys. I'm Wes the Dental Guy.
And I'm John the Dental Guy, and we are excited to be back with you as we are really getting this year rolling. It has been awesome to just start to get some feedback on these new episodes that are dropping out there. People getting excited about what this next year is bringing. If you haven't already seen it, if you want to send us questions, we have this new thing. Wes, I got to give you credit. I mean, you made this happen. Tell our listeners, if they're not watching the YouTube version, what can they do to actually contact us and maybe even get their questions on the show?
Yeah, you may have already seen it in some of the previous releases, but you can text the Dental Guys your questions at 865-544-8954. And listen, now, there's no way that we're going to be able to solve all your problems and answer your questions about your treatment planning. No, that's not what this is for. So if you send those, we're just going to push those to the side. Hopefully you'll send some legitimate questions about maybe bees.
Hopefully mainly bees.
Right.
Or what you might want to see on the show.
Right.
Which, I mean, might be about bees, but if it's not, it might be about, treatment plan philosophy. It might be about, root canals. It might be composites. It might be bonding. It might be veneers, whatever. We've talked about so many things over the years, Wes, and now you have a way as a listener to be able to directly connect with us. Tell us what's messing with you and how are you trying to take it to the next level, because that's what it is all about here with us, with the Dental Guys. And Wes, I just have to tell you, I had this crazy thing happen. So as most of you know, both of us have had opportunities over the years to get to do some speaking, which is a really fun part of what we do because you get to connect. It's all about passionate people, right, Wes? I mean, it's finding people that are passionate, and it's becoming harder and harder, I think, to get in a room with people like that because a lot of people are going more online anyway. So when you get in a room with passionate people, you get to speak, you get to talk about what you're doing, hear what they're doing, nothing like it. So I was recently speaking at an event up near DC with an awesome oral surgeon and his referrals, and we were talking about implant dentistry and lots of other things, and it's great. This is my second time being with them, so I kind of got to know this group a little bit, and we're, about halfway through the morning. Everybody's had a little coffee. It's time for a restroom break. So it's, 10:30 in the morning, restroom break. All right, see you guys in 10 minutes. And the surgeon walks out, a couple of other dentists walk out to go down to the restroom. We're at a Ritz-Carlton, very nice place. In the, on the floor, there's several lecture rooms, or there's several meeting rooms. And next to us is a meeting room full of people. And as they're walking back, I come out because I had a couple people ask me some questions at the break. So I walk out a couple minutes later and I see oral surgeon is in the room next door, along with another dentist who you and I both know, I think, who went to the residency near where you are. So she knows you. And I hear somebody say, oh, this person has
I'm going to give her a shout out. Shout out to Chelsea.
Yeah. Balderson.
Right? Because
love it.
Balderson reached out to me and said, you aren't going to believe this. I'm sitting here listening to your buddy, and someone just had an MI.
Yes. So the word on the street as I go past is this person's having a seizure. But when I look in there and I'm watching what this oral surgeon friend is doing, it is not seizure protocol. There's some chest compressions going on. And I'm like, whoa. And, there's 20, 30, maybe 30 dentists and such around in this group. And I see this and I'm like, oh my gosh, this is the real deal. So I walk in there. And sure enough, this lady is having a heart attack. So they're in the midst. Now, interestingly, and might be a slight segue to our topic tonight, she has dentures in. They're trying to give a breath, right? They pop the dentures out. Well, as they pop the dentures out, her tongue and her tongue basically occludes the airway completely. Malampati of, I mean, she's got nothing. There's no airway to be had. So there's no ability to get breaths. So I'm watching this go down because, I mean, there's nothing I can really do. I'm just there kind of, make sure everything's good. Hotel personnel are there within about 2-3 minutes. They did not know what to do. And so, of course, we're direct. Call 911, first of all. Oh, yeah. Okay, we'll call 911. So call 911 and get the AED down here. Get the defibrillator down here. They're like, yep, absolutely. So they run off. So now we're into full-on CPR mode, right? And no airway again, but chest compressions, as most of us know, that's the key, right? So chest compressions, we're going. This surgeon's highly trained. You can tell he's been in this situation many times before. Came to find out he's done this multiple times on airplanes. Just, I don't know. Some people are just magnets for this kind of thing, right? So he's doing his thing, giving the compressions. No one knows where the AED is.
Oh, man.
No one knows. The hotel people can't. They said it's like locked up behind security, and the security guy, they can't find him, and he's the only one that has the key to it. So here we are, Ritz-Carlton in a very nice area, and we have no access to a defibrillator. No one has it. Meanwhile, we're waiting for EMTs to show up. 15 minutes goes by. Now, I have done training on CPR, as has everyone listening to this probably. And, I don't know how long you've done training on the little mannequin for. I've never had to give actual CPR except one time for about 2 minutes when I was in dental school and I was doing like a little residency at the hospital, a mini residency. And I had to do it for like 30 seconds. So this surgeon, has been doing CPR chest compressions for 15 minutes.
Wow.
Now, I had no idea, really. I knew, but people had told me it was very physical. But thank God, this guy was in shape, good shape. He's doing it. He's doing his thing, but he's sweating. I mean, it's serious. So finally, EMTs show up, no AED for 15 minutes. So they get in there, they take over the scene. We're all just standing there like, what do you do? There's people around. This was like a group of older ladies. And they shock her. They give her epi. They do chest compressions. They shock her. They give her epi. They give her and I guess the rule, according to what I was told by EMTs, is if you do 3 rounds, chest compressions and shocks and epi and Narcan, which is interesting. They give everybody Narcan, I guess, just as a general rule, just in case. And if you go through your 3rd round, that's it. So 1 round, 2 rounds, 3rd round, and we're like, oh man, this person's going to die. And here I am giving this lecture, like, what do you do, right? So on the 3rd shock, she comes back. She comes back. And now she didn't come back, like, hey, everybody. I mean, she came, but she had a pulse. She had a regular sinus rhythm. And they got her on the car. They got her on the stretcher, brought her out, and she survived. She survived. We found out later she had survived. Craziest thing. And once I knew that, like, she was hopefully okay, you're like, oh my goodness, like the adrenaline dump of everybody involved is crazy, right? Because you're just in this mode of like, oh my goodness. And of course, I did very little. I'm going to take very little credit except being there just in case, I guess. That's all I could really do. Chelsea was in there doing her thing. I mean, seriously, she really knew what she was doing. And the surgeon, amazing. So we go back. Now, what do I get? Now I have to follow that. I have to go back into the room.
I mean, how do you even settle the
situation? What do you do? I mean, we're in the middle of this lecture about, like, full arch implant dentistry. And I'm like, all right, we're back, and I felt like I was like, it was like a hard segue on the podcast from, like, say, a guest you might have that was really not, like, kind of like a train wreck, and then you have to somehow bring it back and get people re-engaged. It was crazy. So
I guess if you're listening to this, like, and you're thinking, man, yeah, I've done it, I'd like to hear from you. Yeah, send us a text, send us a message.
And from here on out, anytime I ever do any type of lecturing, it's going to mess with me. I'm going to ask at the front desk, is there
where's the AED?
Do you have access to an AED? because I just got to know.
I mean,
Can you imagine?
It's pretty unreal that they had it locked up, you know?
Yeah.
I mean,
no one knew where it was. No one knew how to get to it.
basic
And I
life
mean,
support training, I think, even has like the people coming saying, hey,
Yep.
the trainer would ask you, like, do you guys have an AED here? Let's practice actually going and getting that. Get yours. Let's look at it and make sure it's working properly. Yeah.
Yeah.
Wow. Well,
Yeah, it
thank
was a
goodness,
crazy. It was
right? You guys, the
Yeah, we were
person
there
that,
at the right time.
We're at
It
the
was
right
the right
time.
time, the right place, the right people, and and I think had she not come back, it would have been a very different day. So I'm
Yeah.
very thankful that we were at the right place, the right time. But I mean, no, I don't know that I'll ever have another experience quite like that. So
That's
with
crazy.
that all said, as we were talking about this before the show, there is a segue to this, I promise, because one of the things I mentioned back in episode 150, and if you haven't listened to that, you should check it out, because it was kind of a re-release or redrop of kind of what we're doing now and going forward. And I mentioned for a moment that during that, right before that show, I just come up from IPRing my wife's teeth. And I said a lot of words after that about what she had done. I said something about modified dome and braces to close the diastema or keep the diastema closed and da-da-da. Everybody, and I think everybody, if you didn't know what I was talking about, you're like, what in the world? But suffice to say that Airway has messed with us over the last 5, 6, 7 years now, since Wes and I began taking the continuum out at Spirit Education. And in between, and really, we were at a weird time. It's kind of like, they talk about generations. You have your millennials and your Gen X, but then there's this weird transition year. I feel like we were those people where we started when the focus was on occlusion as a cause of bruxism, as the primary cause. And there were other things. I'm not trying to simplify, but occlusion was a primary focus. And there was
especially in dental school, I think, whenever
Yes.
you first learn to mount your own cases, and you may be in dental school listening to this right now and you're thinking, hey, yeah, we're doing equilibration. We're learning how to equilibrate. We're learning how to put people in centric relation. And you might have had equilibration done to yourself in dental school as a case study or as an example, whether it be on the model or in the mouth, actually. And so, this interference, the number one interference is the mesial buccal cusp of the, second molar on the upper. And so, does that cause people to brux? We were taught, at least in one camp, John and I, that occlusion can cause people to brux and was maybe one of the primary causes of that, right?
Yep. And then all of a sudden, in the middle of our training toward this advanced idea of how to think about big picture cases and occlusion and all of this, I felt like this bomb got dropped, which was, what if what's going on with why people are breaking our stuff, even when their occlusion is, quote, perfect, even when their occlusion is, quote, perfect, is there some other component? And could it be related to what's happening with their airway and breathing?
Well,
it got dropped.
I think the thing that happened here was in the midst of our training, there was a lot of behind the scenes literature that was starting to kind of surface and Frank even had to go back and actually, we talked to him on our podcast. Maybe it was at Summit. And when we were interviewing him or talking to him on the side, I can't remember. But I know Frank had to go back and actually look at what was happening. Did he diagnose patients correctly? Did they brux for X reason? And was that the reason that they were breaking things? They broke their teeth first. Now they're going to break their rehabs, or in some ways they're going to perform this whatever type of wear pattern or pair function, I should say, again. And why are they doing that? What's the etiology, right? Is what Frank was asking. Am I right about this? Well, then there was things that came out. We know patients, right, if you're listening to this, do brush their teeth if there is airway resistance at nighttime. Not everybody does it, but most do. In fact, if you go to a sleep test and you actually watch people that are undergoing an apneic event, right, or a hypopneic event, right, where their blood oxygen level drops a certain percentage, to compensate for that, they tend to have a parafunction where you'll see anterior
protrusion
wear patterns, right? You'll see protrusion, right? 80% of people clench their teeth during the day if they're clenchers, right? Only 20% people do it at night. So that's what we were taught, right, at Occlusion 1 at Spear Education. But then they threw this out there. They said this. Kevin Quishan said this. I love Kevin. Love to have him on the show this year. Kevin said this. He said there's 3 reasons people clench their teeth at night or have parafunction, right? Maybe not clenching, but some type of parafunction. First reason is that they could be stressed, right? Stress can induce nocturnal parafunction. Number 2, he said, serotonin reuptake inhibitors. We all know that those, even on the package, the FDA lists that as one of the side effects, is that these patients that have anxiety or whatever the reason they're taking SSRIs, they have a parafunction at nighttime that can sometimes present with muscle tenderness, things like that. Or actually, in worst case scenarios, if they've been doing it for a long time, you might see damage to their teeth. And then the third thing that Kevin said, which made John and I look at each other, right, was patients clench their teeth or have parafunction at nighttime because of airway problems. Meaning like, what? Meaning like if you don't breathe right at night, you brux, you have parafunction? And so we didn't really even know what he was saying, because this is like Spear 2 for us. You know, we had taken facially generated treatment planning, and there was no mention of airway at that time. This was years ago, right?
Yep.
And then Kevin says, there's this 1/3 thing. And then their literature starts coming up onto the thing. And like, you're looking at all this literature.
And Wes and I had taken a separate, I felt like at that time there were 2 separate like tracks going on. There was the track of, hey, there's this appliance we have.
Yeah.
That can help sleep apnea. Okay, it was over here. And I remember seeing Jameson Spencer at Hinman meeting talking about this, going, hey, we can help people that have failed CPAP with this mandibular advancement appliance. And he was talking about it, and I was like, cool, this is really cool. This is FDA approved.
Taran Agarwal was actually hosting events at his place.
Yeah, but this is back in maybe 13, 14, and this wasn't new information, but it was just kind of getting out there more. And I remember when we got to Spear and Quishan said that, I'm like, whoa, ho. But I still felt like it was 2 separate lines. It was like, here's this thing of how you could help someone with a problem with apnea with these appliances. And here over here is facially generated treatment planning, or how you think about where to put teeth in the face and how to design occlusions. And there was 2 separate lines. And all of a sudden you started to see these 2 lines coming together where you're like, whoa.
Yeah, what was interesting is as we're going through processing this, you know, they came in and they talked to us about, at one point, like, do you want to treat TMD further, right? So they said there's a second course, Occlusion 2, or whatever they call it, and they said if you want to learn how to go to the next level as far as treating TMD in your practice and going beyond just traditional appliance therapy, flat plane appliances with cuspid rise, CR appliances, how to, you know, we learned how to put patients in CR predictably, learned a decision tree. It's very thorough. I mean, you could take from that and actually build other appliances if you had some other knowledge, or you could go on and like take a second occlusion course, which they still have, advanced occlusion. But then there was this airway thing, right? And we immediately said, this seems to be something we should be listening to, because there were other people that we respected, like Jamison Spencer, Steve Carstensen. We also knew Michael Gelb at the time. And then also, when we see people, the inventor of the CPAP was going to be in this lecture.
Yep.
And John and I just looked at each other and said, we need to go here.
Yeah. And we weren't really sure what it was going to be about, because I think in our world, in our minds, we're like, okay, we're going to learn how to really make these appliances that could help people to get better who failed CPAP. We knew that was important to understand science behind that. But this occlusion angle was starting to mess with us. It was starting to make us think. I remember we went to the airway workshop, and we were like, the airway prosthodontics workshop. And I remember they asked, why are you here? And I remember I said, I just don't want people to break my stuff. Like, that was my start. It was like, I just don't want people to break my stuff, because if I get occlusion right, you're telling me that it can still be a problem even if my occlusion's perfect. I want to learn how to control that. And all of a sudden, fast forward, because we could talk about this for hours. So fast forward several years later, after several courses later, and I broke my wife's nose.
What? What are you saying?
So we go through all of this, and we have to condense it. We're going to talk a lot more about it. Don't get me wrong.
The phone call, though, before John goes into this, I get a text. I knew his wife was going through these things, and he'll talk more about what was actually done. And I get a text, and John is in somewhere in North Carolina, I can't remember, and he said, dude, Ashley's temple was bruised today on both sides. And of course, I knew what was happening, but the patient, I mean, John and I are doctors, dentists, and I've seen Ashley in my office for some update scans and things, and I'm always asking Ashley, how you doing, what's going on. From the patient standpoint, it's always interesting to hear. But imagine you're the patient, and your temples right above the zygoma
your orbital rim.
Your orbital rim actually fractures, and it bruises. John, what the heck, man?
Yeah.
You put your wife through this. Tell me what led you to this point with a loved one.
So we go through, and again, I'm condensing greatly for the sake of wanting to talk about the challenges of implementing some of the things we started to learn. But
we're going to get to that. We're going to get to that.
In the end of the show, I want to talk about what we actually did, because I feel like that is what we need to lead up to today, is what we actually did to her, frankly, because I felt like it was done to her. She wanted to do it, don't get me wrong, but it was basically, you have to believe in this. And both of us, when we heard the truth,
you talk about it like it's some faith. Right.
Well, but the thing is, you have to. Well, here's the way I'll put it. Okay,
because there's people out there, John, that say this is a fad and that it'll come and go and it's not here to stay. And that word belief, right?
Well, I'll tell you. I mean, I will make this statement without qualifying it too much, because we don't have time. But you're on the wrong side of history there if you think that's the case, because you're going to be proven wrong. You already are proven wrong. The data is out there. The literature is overwhelming. It's not a new thing anymore. It was a new thing in 2008. It was a new thing in 2009. That was when Jeff Rouse, for instance, started really diving into this. And I remember when I started seeing out at Spear, pictures of Greg Kinzer and Jeff Rouse together with a glass of wine developing Seattle Protocol. And I was recently out there just a few weeks ago taking advanced treatment planning, and one of the things that we started to understand from Greg and from Jeff was all of this data that came out and what brought us down. And you have to understand that the way we think about things, and let me just condense it down to this. When we first learned how to treatment plan in a real full arch manner, now this could be Kois, this could be Spear, this is not Spear only. This is just what they did, okay? Because I think they're doing a really good job with this. But we were taught that everything is dentures in a way, right? Where you put 8 and 9 in the face was where we began. And it's still where we should begin with our treatment plans. So where you should put 8 and 9, and then where 8 and 9 are, then you put 7 and 10. You put 6 and 11. You look at your occlusal plane. You look at your curve of Wilson, your curve of Spee, your Fox plane. And then what comes next? Your buccal corridor, right? We need a buccal corridor that's full. So what happens if you're doing your denture setup and your buccal corridor is deficient? Well, what do? Well, you probably have your teeth set too lingual, but you can't just put the teeth outside of the wax because they'll just fall out. So Greg's like, well, what would you do? You have to shift your wax rim. You have to make your wax rim wider so that you can put the teeth where they belong, because the teeth belong where they belong in the face just from an aesthetic standpoint. But guess what? At the same time, what are you having to do is you're having to change something about the tissue and the bone, potentially. And again, we could dive super deep today. We're not, maybe more when we talk about, we need to get Bacow back on. We need to get Gunson back on. We need to get Kinzer back on. We need people that are much more qualified than we are to talk about this. But just believe here that it messes with you if you start to think, okay, if the teeth are going to go where they need to go, sometimes you can't put the teeth where they need to go without moving the jaw, without getting the bone and the tissue where it needs to be, or else you're just going to push the teeth right out of the tissue. And how many cases have you all seen in your practice with tons of recession, premolar extractions, a small maxillary arch, where you go, whoa, 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 I love to do ortho here, but I can't because I'm going to push the teeth out of the arch. I'm going to push the teeth out of the bone or out of the tissue. So as we start developing these ideas of what we saw when we were challenged by what's going on with parafunction and where, now it goes, you get to this point of, wait a second, if this is real, how do we start? How do we make, if a mandibular advancement appliance is your gateway drug into this world? Because for many people it is.
Or
well, I'm saying as a dentist, if you're like, hey, I want to get into airway, whatever that means, many times it's just, well, how can I do something that's a profitable procedure for my practice that might help some people to be better? Well, mandibular advancement appliances for many people are the gateway drug. But then you start to ask the question, Wes, what if someone doesn't want to wear an appliance or CPAP or whatever for the rest of their life? That's what Greg Kinzer, Jeff Rouse refer to as a difference between controlling a problem and resolving the problem. So Wes and I were literally just destroyed by these conversations out there of like, not just the airway thing, but getting into worn dentition and talking about, you know, what do you do here to get teeth where they need to be, to get jaws and tissue where they need to be, to make room? How do we deal with tongue ties? What about functional problems, functional habit problems that we used to think were just ortho relapse, that were just because people couldn't breathe? All these things start to mess with you in adults, let alone kids, which is a whole other discussion. But just in adults, to keep it limited for tonight, you start to get to a point where you go, okay, so if you read the literature, if you understand anthropologically that 1,000 years ago, everyone had room for their wisdom teeth. Everyone. Jaws were huge. There was no bottle feeding. There was hard foods. Everybody's jaws were big. Everybody had room. And over the years, due to lots of things, including changes in diet and changes in, microevolutionary changes in our jaw, due to diet, due to changes in our habits, due to the Gerber baby food phenomenon, due to all the things that have made our jaws smaller, and due to the lack of tonsillectomies, adenoidectomies, due to insurance changes in the 80s and 90s, all of a sudden, people's airways and jaws got a whole lot smaller. And now, all of a sudden, we find ourselves in this world of, it's not everything to dentists, but it's a big, big factor. So what do you do, Wes? You get back from this, because we were in the same world. I used to think Jeff Rouse and Greg Kinzer, they were 10 years ahead of us. Now, they were ahead of us. I know they were ahead of us. But I thought when I heard from them that they were 10 years ahead of us. Turns out they were struggling with the same things we were on how to take this information and then digest it and implement it.
Mm.
So let's talk, Wes. I mean, let's talk about, what do you do with this? What do you do? I'll tell you how it ended up for my wife, because it's easy to talk about how you treat it. That's actually the easy part. The easy part is the treatment, even though it's kind of weird. It's crazy, but it's actually not too hard if you have the right people. But the hard part is implementing this idea into your practice of resolution, control. What does it look like, Wes? I mean, what does it look like?
There's a ton of limiting factors when it comes to implementing, anything in your practice. You could be limited by capacity, right? I mean, you just don't have enough room to put people. Where do I put people for this? I don't have enough time for the conversation. So the capacity of your practice is such that you just don't have time. You're just doing fillings and crowns, and you do the, full arch rehabs, and it's just your schedule's humming. A lot of people are like that. The next thing that is a limiting factor is where you get trained. Are you even trained to do this? And where do you go? Can you take time off? How much time does it take? Mm-hmm. Another limiting factor to implementing this is our teams are different these days. Staffing is different these days. People don't stay in the same place as long as they used to. Some of that may change. We don't know. I mean, this type of world that we live in today is a where employees walk in and they turn in a 2 weeks notice because they're moving across town. There's very little loyalty anymore in mid-sized towns, even to larger sized towns, and from what I hear, even in small towns where there's multiple, dental offices in small towns. Maybe you are practicing in a rural area and you're like, why do I even need to consider this? I'm doing well. So your limiting factors, you're just not even interested. What does that mean for you? And
that's where it comes back to, you only treat what you can see.
That's right. You only treat what you can see, and sometimes it's best to be blind. And I think
it's easier.
It's easier. You've got to decide, okay, if you're going to treat certain types of diseases, you need to know why these diseases happened. Dennis Tarnow said this: there's only one correct diagnosis, there's many ways to treatment. Well, we need to know why this is happening. And implementing skeletal diagnosis, that's what we're talking about here, is how somebody grew, how they got from, got to where they're at right now, where they're having symptoms of edge wear, pathway wear. They have teeth that have relapsed. You see things that you start to open up a can of worms. If you understand the right questioning, right? You start to open up a can of worms of, how do you know this about me? Right? Mm-hmm. You get those answers. Are you ready to receive that as a dentist? Do you have the time to? And I don't want to scare people away from this, because the implementation of understanding airway diagnosis, or just really skeletal diagnosis, is the hardest thing you will ever implement. The easiest thing that you can implement is things that you already know, like John said. We know how to implement, how to diagnose a decay. Even a new hygienist, it's easy for me to calibrate her to where do I draw the line as whether this needs a crown or whether it needs a filling. Because we can look at a picture and we can say, this is where I'm going to crown teeth, this is where I'm going to do fillings. And we all know associates deal with that coming into their practice. Like, when do you crown a tooth? Well, that's pretty easy. What about root canals? We all know what irreversible pulpitis is. We know what necrotic teeth are. We know how to test for them. We know how to communicate that to specialists. What does it take to do this? It takes a lot. It takes a lot out of it.
And this is where we go. So we come back from these courses, and our heads are spinning about this whole thing, and we start doing what we know to do, which is to try to gather data. Because in order for you to understand whether or not you can treat things, you have to have enough information to know what to do. And we'll leave it at that, because again, we could go super deep dive into the data collection. But suffice to say that in my mind, I was like, gosh, this is such a beast to try to implement in my practice, to train, for everyone to understand what's really going on and to know how to talk about it. I'm not getting paid anymore for it, which that's not the main motivator, but it's still something you have to think about. You have to understand that this is not a lot. This can't be just a lost leader in your practice. It's not going to be the thing that you're going to hang your hat on necessarily. And also, as times were starting to change, especially post-COVID, you don't have necessarily the continuity of the team that you wish you could have. And of course, dental schools, as usual, are 10 to 20 years behind. So you have to decide. So we start gathering data. Wes and I gathering data in different ways, whether it's home sleep testing, pulse oximetry, there's a lot of different ways that you could look at this. CPC, there's all these things that were discussed. And we start thinking, what are we going to do? There's this whole Seattle protocol thing. I'm not going to go into it. We've talked about it in previous episodes, but just understand you're trying to find out who you can help, and you're trying to find out how it fits in your practice. We've gone through all this. So I come back to Spear a few weeks ago, and I'm talking to the guys who I thought I would walk in there and sit down and I would be embarrassed. I thought I would walk in there and I'd be like, man, I failed at implementation because I've hit so many brick walls of hard to find good team members. I've got some good ones. I've got some good specialists now I work with, and I've got resources. But I thought, man, what are Greg and Jeff going to be doing? And I hear that they're saying, you know what? We have run into so many roadblocks, whether it be training, team, medical community, specialists, traveling, patients, whatever, that we've decided to think about this differently. Doesn't mean it changes anything about what is going on, but it's a different discussion. The discussion, as Jeff Rouse said, was that this is not airway-centric treatment, but it's airway-directed treatment. So this is a part of the discussion, a part of what you know, a part of what you think about, but it is not the only thing you think about. And the thing is, if we make people look more like an ideal denture setup, as I kind of halfway joked about before, if not only the teeth are in the right place, but the wax rim's in the right place, and we can create that in their mouth, the beautiful dentistry with the correct buccal corridors and the correct lip support and the correct lip competence, and we can see that it's not breaking, well, we're also making them healthy at the same time if we understand the airway piece. It's more now that we're using that as a basis for how we treat. It does, but the amount of work of data gathering, it's like, kind of like they said, well, look, we know we're right. But how does that affect the patient's daily life? And we have to have this balance of where you can have somebody come in and say, here's the things I'm seeing. I'm noticing this wear. I'm noticing these patterns. I also notice that you don't have a very wide smile. I also notice that, you've got issues with your tongue, whatever it might be. And I can fix all of that. And if the patient doesn't buy into the idea of what you're trying to do and why, then that's the time where you might go back to the training you have on how to show them using data.
So I want to talk a little bit about something here, right?
Yeah.
This is where people bail as a dentist or as a clinician, and they say, well, I'm just going to make oral appliances. This is just too much. I don't want to deal with any of that. And I get that. because it's easier to just, hey, take 2 of these and call me in the morning prescription treatment plan. And we're not saying, John and I are not saying that oral appliance therapy is not a method of treatment here. And neither have we gotten that from Jeff or any airway course out there. That still has its place. CPAP still has its place. But the people we're talking about here, if you've done enough testing in your office, and I have and John has as well, with sleep machines and home sleep tests, pulse oximetry, CPC, we've done it all, okay? So we've all done it on this podcast. We have patients that come to us and say, hey, I'm not getting any better, right? Things are a little bit different, but they're not completely. Or your patient that is severely apneic, that cannot tolerate CPAP, that doesn't...
Well, I just look at it even differently, and I'm not just trying to contradict, but I'm even at the point now where I'm like, I'm looking at it just dentally. I'm like, it's your 3rd ortho relapse.
That's right.
You know,
it's,
you now
it's
have
a compounding thing that
you
these
have an
patients,
open bite again after your 3rd orthodontic treatment.
All of this stuff.
Something that's going on here that's making it to where your teeth keep pushing forward? Is there something going on here that's causing you to constantly break that veneer on number 8? Because you can't, I mean, you can see the scalloping of the tongue and you can see whatever. And it's almost as if, like you said, Wes, we're not saying anything about these control strategies like CPAP or oral appliance therapy. They're all awesome. But what's really messing with us is what happens, what can you do to actually fix these patients so that, number 1, they can get better, but number 2, that you can have more predictable dental outcomes. It comes back almost to the first reason we ever started down the journey is, in the end, if you can do things that create a stable functional occlusion of people not breaking stuff, guess what? It's probably also that their airway is better.
That's right.
At the same time, it is absolutely going to be correlated. They have wider buccal corridors. They have wider smiles. They have more teeth. They don't have missing premolars. They don't have problems with their tongue pushing their teeth back out. They don't have problems with edge wear and pathway wear. It's not that it's all about it. It's just that it tends to go together with our aesthetically driven, facially driven treatment planning. And if you can kind of get that, you have to understand the airway piece. Then it's a question of, well, how do you take a new associate dentist or a new hygienist who has basically doesn't even know what material they should use for that number 12 crown or what scaler they should use for the distal of number 2? And how do you take them through this journey in a way that is the lowest hanging fruit? In other words, what are the things that they need to identify? And can someone do full mouth rehabilitations, for instance, without understanding what we're talking about? And I think the answer is, well, they probably can. But it's, how do you have these conversations? It's almost better, like Wes said earlier, to not see it. It's easier because then you're just treating what you see, and what you see is broken teeth or worn teeth, and you're like, well, we'll just treat this like we did back in the 80s.
Listen, there's nothing wrong with some of you just want to stop at a certain point. There's different levels of dentistry, single tooth dentistry onto quadrant dentistry, and if you want to stop there, you can stop right there. You see crooked teeth, you refer it. You see a tooth that needs taken out, you refer it. You see a root canal that needs to be done, you refer it. And you just do fillings and crowns. And I think that's a great living. Yeah. And I think that's
if you're great at fillings and crowns, that's a wonderful thing.
Let me just tell you right now, the greatest thing about being a dentist is that you get to choose, especially in general dentistry. You get to choose where you stop. And this is fantastic because you can practice to that level and then just understand a little bit of what we're talking about and understand when to refer. Hey, I see that. And I know a lot of dentists right now that are in their 50s, 60s, and even in their 70s that have recognized that there is a problem. They're not interested in treating it, but they know who to refer to, right? They know how to
respect the heck out of
recognize.
that.
And I think that that is really where we need to be as a profession. My challenge to you is, if you're listening to this and you're thinking, well, how do I even get started? It starts with just wanting to know more and where you go, right? We've mentioned a few places, and we love Spear Education, and we love their support for the Dental Guys podcast and over the years. And we would send you there to start, because the very first course that they teach is facially generated treatment planning, and the A in the prescription or treatment planning form stands for airway. And I think if you just started with that course is a game changer.
That's right. It's about becoming aware of it. And I would challenge you, if you do, like as Wes said, I respect so much the dentist who knows what their limit is, and they're okay with that, and they're doing a great job at root canals or crowns or fillings, and doing great quadrant dentistry, doing great composite. We all know how difficult just that is to be excellent at. So what we're talking about here is stuff that's just messing with us. But I do think
the implementation is what's messing with us, right?
That's right. If you
this is the hardest thing to implement. If you're having trouble, don't feel bad.
That's right.
Because if you start asking more questions, you're going to have more questions when you come away. I feel like we're getting to a point, John, in our understanding with some of the leaders in the field, where we have pathways now. We have systematized ways of treating certain illnesses here, and the disease of transverse dimension deficiencies and AP deficiencies. Yes, most of them involve ortho and surgery. There's no avoiding that in adults. Some type. There's some new surgeries coming out, and John will even talk about those maybe in an upcoming podcast. But John, to conclude the show, you broke your wife's nose.
Yeah.
Right?
So I'll give you again the condensed version of this story after we've talked about it, and all these things had messed with me. And I remember when, after I understood a little bit more about how to look at these patients, and I started seeing things in my own wife that I had never really noticed before, and I started asking questions about her sleep, and she would always be getting up at about 2:55 a.m. every morning, and she would not dream ever. And she would be a little bit more just tired through the day, you know, just have a headache every morning, every single morning. And I started seeing things, and I started asking questions, and it makes you look like you're some magician when you understand these things, and you start asking patients, and they're like, how did you know that? How did you know that? How did you know that? And so we go, because especially at the time, early on, this couple of years ago now, I didn't even know that I knew enough to even know where to go. So I went to the authorities, right? I went to Becca Bacow in Seattle, orthodontist that we know very well. We've talked to several times on the show, who's an authority for sure in this area. And so the diagnosis was made through, long story short, of upper airway resistance syndrome, which in her case, long story short, was because the orthodontist had compensated for a class 3 tendency in her case due to a deficient width of the maxilla by basically way lingualizing the lower molars, and all the lower teeth were really kicked back. The upper were really, everything was very constricted. Everything was very constricted. So we trialed her on oral appliance therapy to see, would it help her symptoms?
And she's already class 3.
Well, she was barely class 1, but you could tell if she had been, you know, if you uprighted the teeth, she would be in full crossbite.
Yeah.
Okay, but she was barely in class 1.
So a mandibular advancement device, well, yes, it'll open vertical dimension, but it cannot change the transverse dimension. It can't.
All we're trying to figure out is, by giving her more airway, potentially, is would we see her subjective symptoms improve? and might even some objective symptoms of pulse oximetry improve. So we did some testing. Again, long story short, determined it was incredible difference with the oral appliance. Incredible. She's dreaming for the first time and she can't remember how long. She's not waking up in the middle of the night. She's not having headaches in the morning. But at the same time, we started to see this little bit of an anterior open bite start to develop. She had just a tiny little bit of overbite. And now it started to be end on. And we started to see the tongue pushing on teeth. And at the same time, the oral appliance is helping her, but we're seeing these changes happening. And and she says, I hate this thing. Don't want to wear it the rest of my life. And I'm like, well, let me just tell you what that means. Right now, at the time, we had some knowledge about alternative surgeries to full-on SARPE, surgically assisted rapid palatal expansion. Most of you have maybe remembered that there's a way with orthognathic surgery that you can split the palate. It's a big-time surgery. It ain't easy, but it's doable. So we go to Bacau, and we're like, Becca, what can we do here? And she says, well, now that you've trialed out oral appliance therapy, we know it's successful. We've seen AHI. We've seen results with pulse ox. We know it's potentially going to be very successful if we can make her jaw wider, because it really was more of a width problem for her. So long story short, go into orthodontics, which she of course hated, but knew why. And we did, the surgeon out in Seattle did what's called a modified dome procedure. Again, long story short, essentially instead of doing a full orthognathic approach with big time flaps and everything, now we can use TADS, mini screws, and do what's called MARPE, or mini screw assisted rapid palatal expansion. So she has a mini screw assisted palatal expander placed and a cut made right between 8 and 9 up near the apices of the roots to basically start the split of the palate. Because we're out of town, she didn't do the full dome, which would have been zygomatic cuts as well, or above the maxilla, because we would have had to stay in Seattle for a couple weeks, and she didn't want to do that. So
you don't want to have an orbital blowout.
That's right. Right. Exactly. So, oh gosh. Yeah. I didn't tell her much about that. But so she has a single cut made. We go back home and we're turning the wrench. Now, anybody who says this is easy has not done it, because what's happening with MARPE, and again, Greg and Jeff can explain this. I've learned so much about this, even since she had the surgery, that when you do MARPE, when you do these turns, you're doing more than what you can do with SARPE. When you do the full palatal split and everything is detached, all you're really doing is expanding alveolar width, right?
You're not moving anything above.
That's right.
Right.
Your nasal volume increases, but you're not doing anything to the face really. You're just doing just the maxilla. Well,
this is why some people too, right, that are deficient as far as their dolichofacial, they end up going for plastic surgery. They have cheeks done. Radius in my office is done to a lot of people that are dolichofacial to rebuild the cheekbone. And if you see where I'm pointing on the screen right here, this is where Ashley gained. And first time I saw her after this thing was happening, I was like, oh man, her orbit had
cheekbones
expanded.
For days.
Yeah. She's got cheeks. She's got cheeks. She doesn't look deficient. And you're thinking, well, that's just the buccal fat pad disappearing. No. This is bone.
Yeah.
This is bone.
we go through turning this wrench, right? This jack screw for about a week. And it's pretty terrible, because what's happening with MARPE is you're not just expanding there, but every suture between bones from the maxilla up to the orbit is having tremendous pressure applied. You're trying to split the palate completely, but you're also putting pressure on the rest of the face. Well, about 5 days in, her nose broke. And I called Becca and the surgeon, and I said, we think, she can't even touch the border of her nose. And the surgeon's like, that's great news. I'm like, dude, like, yeah, that's what's happening. Like that often happens is that in fact it can even correct deviated septum sometimes if you because you're breaking and expanding. And then she has slight orbital suture release.
Yep.
And we see bruising up around the orbital sutures. And so her whole face is under tremendous pressure. Now, again, having watched her go through it, it's hard.
Yeah.
Now it's a far, far cry from orthognathic surgery, right? So we're talking about a night and day difference between orthognathic surgery and this. So I don't want to overplay it, but it's still hard, right? So she goes through this change, opens up a massive diastema, palate pops loose. She has about a 4 millimeter diastema, which is minimized by braces, maybe even 5 at the end. Increases her palatal width by 15 millimeters. 15 millimeters, crazy. And that's at the posterior. So then we go into a wire to close space. Long story short, she goes into clear aligner therapy. We're finishing the case now to just get everything perfectly aligned. In her case, she didn't have an AP problem, which made her eligible to do MARPE without having to do full-on jaw surgery. We didn't have to add to teeth. And her case is, quote, the easiest version of this. If you could see how different, I'll have to go back at some point. I'll have to put some pictures up. Just looking at her lower molars and how upright they are, the difference in terms of tooth position. I mean, she was literally in almost a full crossbite prior to surgery, and it completely corrected it without orthognathic. So
I'm excited. Maybe we can have Ashley on the podcast, actually talk a little bit about maybe a small segment with her on there. Talk about her perspective, the symptoms she had before, how she's feeling now, because I know she's almost finished. And super excited about that. Hey,
yeah, crazy. But you know,
your wife's
this is what it's all about.
You broke your wife's nose. You convinced her to, to break her nose, and I'm excited about.
She is so happy about it.
Oh,
now.
Yes.
I mean,
save that because I'd love to get her reaction. Right. I mean, this is the things that are really messing with us.
Yeah.
One is, how do you implement this? Number 2, if you're in a rural area, who do you refer to? I mean, John just sent somebody across the country. It was a little easier because, I mean, he lives with this woman. So, I mean, it's a flight. It's surgery on the West Coast. There are limited people in the United States that are doing this. There's a few, a very small few. It's not something that you're going to just refer down to the local hospital, in the ENT or over to the oral surgeon. Oh, they can do that. Be careful, right?
That's right.
I think
Jeff Rouse says he sends everybody out to see Mike Gunson as a requirement. They don't have to see him, but they don't have to have it done by him, but it has to be one consult is required with one of the few people that's doing it at a super high level. That's how, and this is the guy that basically with Greg invented Seattle Protocol. So if they are struggling with who to send to, it makes me feel better about where we're at, Wes, of trying to find the right mix of how to truly, truly do this. And in podcasts to come, I guarantee you we'll be talking with the people that we're actually referring to much more about where we are now. Mike Gunson, Becca Bacow, I know these are people that'll be on. Greg, Jeff, they're ready. They've already told us. They're like, come on. Why aren't we? We're ready.
I'm excited about that. Hey, if you have comments or questions, text us, 1-865-544-8954. Send us a text today. Maybe we'll even read your text on the show. And that would be awesome. I think the thing that's coming up here real soon, John, is the meeting, right? The big meeting in Charlotte, North Carolina, the Academy of Osseointegration annual meeting. And John and I will be there. And so as we conclude the show tonight, we hope that you will be there. This is going to be an amazing meeting. Go back to episode 150, released on January 2nd, where we talk about peri-implantitis, peri-mucositis, and what we will be asking the experts. How do we treat this, and is there some magic sauce that we can use? I mean, we are going to talk to some great names. We're asking to speak to Steve Chu. We're asking to speak to Dennis Tarnow again, Michael Norton. All the big names will be there. It's going to be amazing. Head over to osseo.org and register now. Coming up, John, what's the dates on that? I'm just on March 7th through the 9th.
7th through the 9th in Charlotte, and which is kind of our backyard, which is sort of cool. We can actually, drive there potentially, which is that's never happened. But we're excited to get to actually, talk through some of the biggest controversies and some of the questions. Does anybody know how to treat periimplantitis? Is it still a mystery? So come out and see us in person would be awesome, because I promise you, you will say that it was worth every penny you spent to be there, and not just to see us. In fact, we're the least reason to be there, although we want to see you. But in order for you to get involved with an organization that's doing it right, that is going to make your dentistry better and make your understanding better. So connect with us. We look forward to talking more about these exact topics as we go forward. Wes, this has been a great episode. Thanks for letting me tell my story and Ashley's story. It's been a lot of fun. So for Wes, I'm John. And once again, we are the Dental Guys.